Today on Being Well, we are answering all of your questions about menopause. APN's Leslie Taggart and Nicole Wochner from Sarah Bush Lincoln Health System will be here to talk about the stages of menopause and the symptoms that come along with it. We'll learn more about what medications are available to help control symptoms such as hot flashes and if hormone replacement therapy might be an option for you. Stay tuned for this informative edition of Being Well. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255. Rediscover Paris. Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first. Welcome back to Being Well. I'm Lori Banks, and today we're talking about a subject that a lot of you and your girlfriends probably talk about, and that is menopause. And here to answer all of our menopause questions is Leslie Taggart and Nicole Wochner from Sarah Bush. Ladies, thanks you so much for coming back.
No problem.
Thanks for having us.
All right, well, we've got a whole list of questions, some of them generated by, friends and coworkers of mine. So let's get started with just what is menopause and how do you know if you're in it?
Menopause is kind of goes in certain phases. So I think the important part of menopause is understanding that there is something called a perimenopause that starts kind of previous to cycle stopping. That can be when you start having hot flashes and when you can start having mood changes and sleep disturbance and things like that. Menopause is defined by 12 months of no periods. So you're not technically menopausal until you've been a year without cycles, but those symptoms can start long before the cycles stop. And so I think that's where a lot of women get confused, is like, well, I'm still having my period, but I'm having all these other symptoms. What's going on?
Yeah. When do your patients, about what age are they hitting that perimenopausal stage?
Well, perimenopause can start even in your 30s.
Okay.
A lot of the patient's risk factors and body style and lifestyle habits can affect that. But anywhere from 30s, some women might not start it into their 40s.
And then that can last for a few years. Then menopause can drag on for more than just a year, or how does that?
We have some patients that'll go like 11 months and then all of a sudden their period will come back, and they're so frustrated because then that 12-month period starts over again. It's 12 months of consecutive no menses. So.
Okay, and then once you hit that, then
you're considered menopausal.
Yeah. Okay, so what is the average age for a woman to be in menopause?
In the United States, it's 51.
Okay.
So ethnicity kind of plays a role in that too. We know that Hispanic women and African American women to some extent, but more African women have earlier menopause, and Asian women a bit later. But kind of the norm average in the United States is 51. And a lot of that has to do with our diet here in the U.S. and our lifestyle and things like that too. So
let's talk about existing, lifestyle factors, other health factors, diabetes, high blood pressure. How do those things play into menopause?
Well, obesity is probably the biggest one. If you are overweight, you will suffer more with more of those perimenopausal symptoms. But lifestyle factors such as tobacco use is huge. It's earlier onset of perimenopause and menopause in general, as well as alcohol has a lot to do with that as well too. And exercise. If you don't exercise or don't really just, I mean, us healthcare providers preach on that all the time, but it really affects so many things. But yes, if you are out of shape and don't take care of yourself, you are going to struggle with menopause and perimenopause more so than someone who does.
Those symptoms are going to hit you harder.
They're going to be more exaggerated. They're going to probably happen earlier, and you're going to struggle with them longer, and they're going to be more intense.
Well, we chat, actually we were talking this morning about, oh, thank goodness it's cool in here because I was hot this morning. Hot flashes are very common. Let's talk about those dreaded hot flashes. How do you know if you know you're having one, but sometimes, what really defines a true hot flash?
It's really just different for every woman. It's more of a temperature intolerance issue. So it's just, there's a whole biochemical mechanism behind it, but basically it's just women have a sort of less of a tolerance to small temperature changes. So that's what triggers, in your 20s, you can go from, like a warm room to a cold room and back to a warm room and really it's a little warm, but for a menopausal or perimenopausal woman, that slight temperature change, your body can't compensate for that. And so that triggers a hot flashes. Sometimes anxiety can do it as well. So I don't think there's like a standard hot flash. I think everybody really kind of has a different experience with it. But like you said, if you're having them, you will know.
But it's not always just profuse sweating. No. It can just be you're just really, really warm.
Some people say it feels like fiery furnace, like you're burning up from the inside out. And some women sweat a lot with it. Other women don't sweat at all. It's just really different from person to person. But 75% of American women report having hot flashes during menopause. So it's pretty good likelihood that you're going to have some hot flashes as you go through menopause.
Is there anything that you can do, any medications, supplements, anything you can do if you're really suffering and you're like at work and you are sweating and then you're freezing? If it's really interrupting your life, is there anything you can prescribe for it?
There is actually a new treatment. It's a low dose of generic, or it's a branded called Brisdell now, but it's low dose Prozac that given at lower doses than what we would use for anxiety or depression has been shown to help tremendously with that. But again, we have found that more so just what you wear and, cotton, like your grandma would say, wear cotton and avoid some of those triggers that, like stress and anxiety that are going to cause that. Have a fan with you, have water. Those environmental things are, not that the medication's not safe, but those are some much more practical things that you can do. You'll probably get just as much relief doing that as versus taking a daily medication.
Or do what I did, and I started never drying my hair the morning I go to work because we were talking, I would just be sweating. So that's one solution.
Avoid the triggers,
changes.
Yes.
Don't use a hair dryer in the morning. If your mother went through menopause at a certain age, can you expect the same result?
Yeah, genetics are a pretty huge predictor for menopause. So within a couple of years in either direction, most women do follow suit with their moms. Our generation, it's kind of hard because a lot of women, our moms' ages, had hysterectomies because of bleeding issues or other kind of concerns. And now we have so many treatment options available for dysfunctional bleeding and things like that. So we're doing a lot less hysterectomies. But 20, 30 years ago, that was kind of the go-to for treatment of, menstrual irregularity and all of that. So a lot of my patients that I say, okay, let's talk about menopause, let's talk about your mom, let's talk about your sisters, and they're like, I don't know, my mom had a hysterectomy when she was 30. So that, yes, absolutely, mom's, menopausal course does have some predictor for daughters, but in a lot of cases, we don't have that to go back to, so.
Okay. Let's talk about, I wanted to get back to, I jumped ahead there. We were talking about symptoms, so hot flashes is one. What are some other common ones that your patients talk to you about?
Usually some of the earlier ones would be like mood instability or liability, which usually they'll be like, oh, my kids and husband say I'm a jerk. So, and lots of times the patient will notice it too. They don't want to feel like that.
Yeah.
So, mood changes, the temperature intolerance. A lot of them will report increase in weight or inability to lose weight that they normally could, work hard and lose that 2 pounds, where they are doing all the normal stuff, exercising and eating right, and just not losing weight. As well as extra weight in the midsection, right around the abdomen is really common. Loss of hair, but then also gaining facial hair. So you're losing it from your head, but finding it on your chin.
Super.
Yes. And then later, osteoporosis goes into that with declining estrogen levels. So that bone health comes into play with that. But those are some of the more common issues.
And are a lot of that's just related to the changes in hormones,
Yes.
the weight gain and the facial hair? And
And you think about when we are pubescent and starting with this whole maturation process, the estrogen is naturally inclining, but now we're on the opposite end of the bell curve where we're coming down slowly. So when you're crazy because you're a teenager, the same thing happens when you're coming out of that. Those hormones are just
It's really
reversing.
similar. Yeah, absolutely.
So for women let's talk about if you had children or not had children, does that have any impact on menopause? No, really?
I guess there's some theory that maybe a little bit of that plays into it, but no, not really.
Yeah, there's been lots of research trying to find a connection there, and there's just not been a solid study to say yes or no one way or the
And
other.
even over the course of the last, 50, 60 years doing retrospective studies, the average age of menopause really hasn't changed. So, we look at a lot of sort of new research on like BPA and like carcinogens and things that we're exposing ourselves to that probably are not ideal, but as far as, estrogenic activity and things like that and how that affects menopause, we haven't really seen a shift with that. So obviously there's, that's a ... more to come. But yeah, so far we don't have any necessary, other than smoking and lifestyle factors, there isn't really a whole lot that plays into changing.
So the fact that you may have been on birth control for several years has no
Or
impact.
even like if you started your period a lot sooner than the girlfriends in your class, that has not shown to show much difference. It's really, like we said, diet, exercise, and other lifestyle.
And genetics.
Yeah, and genetics, they're huge. In your genes, there's some things you can't change about that.
So this was a question that came up around the office. Is there any kind of blood test or something, hormone test that you can do to decide if you're menopause, especially for a woman that's had maybe an endometrial ablation who doesn't have a period? How do you even know if you're?
We really just go by symptoms.
Okay.
There's not like a blood test for like a predictor of like you're getting close or.
Okay.
Once you're menopausal, we can kind of determine that with a blood level. But as far as the perimenopause, there's no sort of gauge for that. So especially like for women who've had an ablation or women who've had a hysterectomy and still have their ovaries, it's really more looking at the hot flashes, looking at the mood changes, looking at the sleep disturbances and all of that, and just kind of treating it more clinically. I have that conversation with patients a lot. I can draw your blood, but ultimately these symptoms that you're talking to me about are what we need to address. So whether your blood work looks perfect or whether it looks borderline, we still need to address what's going on with your symptoms. So I don't
And even as you're going through or close to menopause, that FSH level is what we check. That changes significantly day to day, even if you're, very close to menopause. So really, and a lot of people just want that proof. They want it.
They want the numbers from numbers people.
Yes. But I kind of feel like it's kind of a waste of your money because, I'll do it if you want to, but it doesn't provide much clinical information for me.
Okay. You talked about sleep disturbances. Is that common for perimenopausal and menopausal women?
Yes.
So what's kind of behind that, and what can they do about it?
It's another, estradiol, estrogen shift that triggers, sleep disturbance. And it's more of a sleep pattern disturbance. So women can typically fall asleep okay, but it's more frequent waking during the night. Some of that has to do with night sweats. The hot flashes that you have during the day are happening at night as well. So whether you perceive them completely or not, they're enough to disrupt your sleep pattern so you don't get really deep, restful sleep. And then, you know, the littlest things will wake you up.
As well as the bladder comes into that too. With
Yes.
decline in estrogen can affect your bladder, so you're having to go to the bathroom more, or there's more incontinence issues. And that if you're having to get up to go to the bathroom, most people will have a harder time going back to sleep immediately. So that
Do you
can add
just,
to
as
it.
we age, you just don't get in that as deep of sleep as we used to?
for
Is that-
different
section?
yes, different sections of your life, like when you're with a new baby and then again with this. But eventually, as the dust settles and your hormones level off, you will get back to where you can get a good night's sleep again.
So let's get back to, we talked about some of the emotional instability. What kind of advice do you have for when you said you do have patients who kind of realize I'm acting a little crazy or very, you know, easily set off? What advice can you give to them to kind of manage their way through that part of it?
Well, and some of those medications we talked about for hot flashes, they're called SSRIs. They are actually used for treatment for some of the mood liability. And again, given at low doses, we find that we can treat multiple symptoms with those medications. And because they're not given at higher doses, we don't have some of the side effects. Whereas, like if you were taking sometimes double or quadruple that for anxiety or depression, it's enough to help take the edge off a little bit, because that's a lot of my patients will say, I just feel edgy. I just feel like the slightest thing can just set me off, or I want to just snap at my kids when they do normal things, or my husband irritates me so easily. So this all very, very normal. And if everyone in your home understands that helps too, to be like, I'm not trying to be mean to you. It's sometimes mom just says things that come flying out. My filter's going away a little bit. And again, all that will settle down too. Once you get through that perimenopause, that's not how you're going to be forever too. So a lot of people don't take anything, and they'll just use other coping mechanisms, exercise, going for a walk for 30 minutes a day just to blow off some steam really helps.
Okay. You had mentioned that you do see changes in your hair and your skin and your nails. What's kind of going on other than, I have wrinkles that I didn't have before?
Well, testosterone changes as well during that, so that can affect some of that facial hair. And again, it's all coming back to the estradiol estrogen thing, where you'll notice a lot of older ladies that their hair is just so much thinner, and that has a lot to do with that. So if you're just conscious of that, maybe not wash your hair as often, because usually when you wash your hair, that's when a lot of your hair is going to come out, or be more gentle with brushing, that kind of thing. You can take a multivitamin, just a daily multivitamin can help with that. Some of my patients really like the hair, skin, and nail vitamin, and there's nothing that will hurt you with that. But just being conscious of that. And again, drinking more water and just helping with your diet will help with a lot of that.
Yeah, estrogen is kind of the hormone that keeps your skin sort of soft and, increases elasticity, so you don't have as many wrinkle issues and things like that. So since that's declining, you kind of have to compensate for that with like more water and the other sort of dietary things that you can do to help with the elasticity of your skin.
Well, I wanted to save this question because we need some time to talk about, and that is like hormone replacement therapy, because we're losing estrogen, and it's a good thing for lots of reasons, but yet it has this downside of causing heart issues. So we're going to spend some time talking about that, about hormone replacement therapy.
I think I can speak for both of us. We both prescribe hormone replacement. We have a lot of studies. There were some studies that came out, around 2002, 2003, WHI, that sort of scared us about hormones, scared the American public, scared providers, kind of everyone, about hormones and risks and all of that. And so I think that sort of reshaped kind of how we look at hormones and how we look at dosing. And so we've continued on with those studies, and what we're finding is that for women who take a low dose of hormones for a short amount of time, and by a short amount we mean around 5 years, and women who are in that perimenopause to early menopause period, that there really aren't significant risk factors that go along with that for the average woman. Now, obviously, there's women who don't who are candidates for hormone, women who've had breast cancer, women who've had endometrial cancer, women who have, serious heart disease, risk factors and things like that. But for the average woman who's for the most part healthy and doesn't have any other sort of underlying disease conditions, it's really pretty safe, and it does have a lot of benefit outside of even just treating your hot flashes. So I think, I spend a lot of my time counseling, sort of like reshaping our view of hormones, because we do kind of like, hormones are bad.
It is scary. I mean, you hear about estrogen sensitive breast cancer tumors and heart disease, kind of makes you not want to take them at all. So how do you determine if a patient is a good candidate? If they're having, I'm kind of hot like once a day. I mean, what kind of determines?
Severity of symptoms is probably the number one thing. If again, like you're saying, if I'm just having a couple hot flashes, then obviously we're not going to jump. I don't want to say it's a big gun medication, but it's not something we're just going to throw at everybody. We try and counsel the patients on, like we've talked about so many times, the lifestyle modifications. Diet and exercise truly does so much that you could control a lot of your symptoms with that alone and not take a single pill. But yeah, if your age has a lot to do with that. If you're a smoker, if you're overweight, your parents' history with heart disease, again, the breast cancer, and if you're good about screening with mammograms, we want you to do that at age 40. That will kind of help stay on top of it. Not that we give that as as long as you're doing that, we're good to go kind of thing. But yeah, severity of symptoms is probably the number one thing. And then we kind of calculate that along with what lifestyle modifications or patient history that particular patient has.
So what hormone, when you're giving hormones, is it estrogen replacement? Is that what you're giving
For women who have a uterus, so women who haven't had a hysterectomy, we do a combination of estrogen and progestin because that has a protective effect for your uterus. For a woman who has a uterus who's taking what we call unopposed estrogen only, which you can do over the counter with estrogen and things like that. So you do have to be careful with that. You put yourself at increased risk for thickening the lining in your uterus, and that increases your risk for endometrial cancers. So it's actually really pretty dangerous. So we do give a progestin to kind of combat that. There's actually a newer medication on the market now as well that has a combination of estrogen and then a SERM, which is a little bit of a different sort of combination that does the same thing as far as protecting the uterus, but sort of in a little bit of a different way than the progestin and some of the risks that can go along with that. So I think we're living in a time that sort of is ever evolving. Even just since I've been in practice, which has only been for 13 years, we have so many new options for hormone replacement, and we're sort of constantly on a quest to find the lowest, safest dose. And so I think we're just, making it safer for women who are, because it's a quality of life issue. And I think for a woman who's suffering with hot flashes and suffering with other menopausal symptoms, we need to have something that's safe that we know is going to manage the symptoms without putting people at a lot of risk. So the good news is that's, I think there's more to come on that. So,
Yay for all of us.
Yes.
All right, let's talk about sex drive. What kind of changes happen, in that menopausal state?
Libido changes are common. I have had it both ways. I've had some patients are like, say my libido is gone, I have absolutely no interest. Other patients report that their sex life is improving. But a common complaint is pain with intercourse or bleeding with intercourse. And because of that decrease in estrogen, like Nicole was talking about how our skin and our face changes, so does skin everywhere else. So there's a natural drying of not just the external vulva, the external genitals, but also inside the vagina itself. So that's what can cause some irritation and pain with intercourse, especially like with initial penetration. That's when most of our patients say that's when we first start, that's when I'm most uncomfortable. And that can be a big deterrent with libido. If it hurts, you're not going to want to do it. So there's Nicole and I encourage patients to use olive oil, as crazy as that sounds, it's a plant-based product, so there's no chemicals in it. Just for a natural lubricant for day-to-day, you think about using lotion on your skin, you can use that day-to-day in the vagina or on the outside, the vulva, but also as a lubricant for intercourse as well, too. It doesn't, for tissue that's already irritated, putting more chemicals on it, like the over-the-counter KYs and all that other,
sassy lube.
yes, that is like liquid fire. So for someone that's already having problems, that's only going to compound that. So we find that olive oil is a great therapy for that. And
Vitamin E,
yes,
coconut
vitamin
oil.
E. Yep.
And everybody has their favorite sort of oil these days, I
Yeah.
feel like.
As
but-
long as they're plant-based like that and not necessarily a petroleum-based product that has so much junk in it, that helps a lot.
I thought I've seen ads for like an estrogen cream.
Yes.
That can
Oh
help
yeah.
too.
It's very controversial because they're actually advertising and using the word sex on TV, which is kind of iffy. But yes, there are the two main ones right now are Premarin and estrace cream, and those are awesome. We usually have no problem with prescribing those because they're mostly a local based medication, so it only goes where we put it. There is some minimal part that can go in the bloodstream, but for the most part it just goes in the vagina, and given for 4 to 6 weeks, most of my patients report great improvement with just day-to-day uncomfortable irritation, but as well as with intercourse too.
Okay. I think we've got about 2 minutes left. I would just want you guys to sort of walk us through what do you tell your patients? What advice do you, because all women are gonna go through this. You can't really
Avoid it.
So how can we make it as positive or as comfortable as possible? What should we do?
I think just healthy lifestyle, kind of being proactive with it and knowing that it's going to happen, sort of already have those sort of lifestyle things in place, exercising and eating healthy and, avoiding smoking. And the things that we talk about for just general health are going to help with menopause. I tell people all day long too, I think we paint this picture of like ugly, ugly menopause. It's awful. And it doesn't have to be that. I think a lot of it is sort of how you go into it. Yes, it's going to happen. Yes, you're probably going to have hot flashes. For some women, absolutely, it's awful. And that's what we're here for. But I think if you can go into it knowing that it's going to happen, it's going to be for a relatively short amount of time, and then it's going to taper off, it makes it a lot more manageable. Than thinking this evil looming menopause is here to stay.
And think of it as a positive thing. A lot of people kind of suffer with this, like, well, now I can't have children. It's that end of an era for them, which is very consuming for us as mothers. That's so much who you are. But think of that as celebrating, like I can focus on me more now, and think of it as a positive thing and not so much of a doomsday, like it's coming.
Oh my gosh. Ladies, thank you so much for coming on the show and giving us just a great, open, honest, frank conversation about menopause. I think you've answered a lot of questions for our viewers.
Thank you.
Thanks for having us.
Absolutely. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Dr. Ruben Boyajian, located at 904 Medical Park Drive in Effingham, specializing in breast care, surgical oncology, as well as general and laparoscopic surgery. More information online or at 347-2255.
Rediscover Paris.
Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center. HSHS St. Anthony's Memorial Hospital, delivering healthcare close to home. From advanced surgical techniques and testing to convenient care for your family, HSHS St. Anthony's makes a difference each and every day. St. Anthony's, where you come first.